Welcome to the Movement Podcast. This show is all about movement, giving you a better idea of how you can optimize the human body to be the best it can be. Hey guys, I'm running the podcast solo today. Dr. Burton is not with us, but I've talked with our guest and we feel we don't need him because Lisa Chase has been on this show before, and last time we talked about her. Now we're talking about her as an author, and we affectionately talk on the phone and we call each other geeks because we could talk rehab, PT, sports medicine, exercise, manual therapy, and all the accoutrements and gadgets that go along with modern physical therapy forever. So we're going to try not to geek out too bad and keep this focused on her body of work, because she's literally taken her history working with pro athletes and general population and arrived very much in parallel where I've arrived in my career with. It's hard to be an expert in musculoskeletal medicine and not have a different appreciation for wellness than we once did. Wellness to me was a frou-frou term until I realized that everything we were doing with our special operators and at the NFL Combine was wellness. A movement screen is not done for performance, and we can't really say we're preventing injury, but we are looking at risk factors in movement. And the one thing, Lisa, that I appreciate that you did in this body of work that I want to talk about is you're really using movement as one of those quick feedback loops and identifying factors. So you can see that progress maybe before they feel it, or maybe before they acknowledge it. You're already seeing signals of mobility, balance, posture, stability, all getting better. And I know we've been doing that our whole career, because when you've got an injured athlete and they're losing confidence, but you're actually seeing progress, they're just not feeling it. You got to glue that together until they can get back in the arena or something like that. So start off, tell me about what made you think, all right, I got to birth this book, because nobody writes a book for fun. I've done 3, and each one was a painful, laborious birth of a guy who would much rather talk than write. Tell me what started this, and we'll go from there.
Yeah. Well, look, I've been practicing over 30 years, and I sit across from patients, and over the years, you hear the same stories, the frustration with having to go to practitioner. Things are only approved if insurance covers it. You know, Practitioners aren't talking to each other. And as a matter of fact, now more than ever, people are turning to AI more than they're turning to their practitioners, because they're just frustrated. And I think they're frustrated because, in the traditional model, we're just basically we're treating pain, right? We're symptom managing. And what I saw is, after traveling for almost 10 years on the pro tour, I saw what it was like to be able to treat the whole person. And so I brought that back to the clinic. And it was amazing when you stop, you listen, you let patients tell their story. I always say the mystery's in the history. They'll tell you what you need to know. And I saw like amazing changes in people that had been to different practitioners, and they weren't getting any better because people weren't really listening, nor do they have the time, because we know the traditional model is basically is very limiting to how much time you can spend with patients.
Right.
And so I saw the changes, and I see that patients want answers. They want, because just looking at AI, they want to have tools. You and I talk all the time about our Oura Rings. There is more and more technology and resources that patients can utilize to take care of themselves. So I said, okay, I'm just like repeating myself over and over again. So why don't I just put this in a book that I can then, use as a tool? Because I'm going to obviously have trained all my staff, but it'll just be a great complement to what I'm doing. And now it gives the power over to patients if they want to learn these strategies, so they can, either have a better relationship or ask better questions with their, clinicians, or they can do some positive things themselves to move themselves into, a better place of healing and get better outcomes.
Now, for our listeners, are you traditionally insurance based, cash based, or do you do both? How does your model work, and how do you get away with being better than the system will allow you to be?
Yep. Well, yes, I'm 100% cash. I've always been 100% cash. So basically, I have to be better, right? Because patients are only going to pay cash if they get the outcomes. And, so I think here we spend one-on-one time. Every therapist gets an hour with every patient. And, we look comprehensively at them and we have a variety of things that can help them achieve what they want to achieve, well into after rehab, into wellness and into performance. So yeah.
Would it be safe to say that even though obviously if the general public read this book, they would come to a therapeutic situation, a rehabilitation situation, more educated and responsible for their part? But
100%.
let's be honest. I've been a patient longer than I've been a therapist. I was breaking bones right after puberty like they were dry wood sticks. I was just running
Oh,
around
God.
hypermobile, trying to play football, just snapping bones, going through a growth spurt. Um, and I've been a horrible patient most of my life.
Yeah.
I put off a neck fusion longer than I should have. I walked around with a hernia for about 4 years, just thinking,
Mm.
I'll just strengthen my core, even though my
Yeah.
abs were
There
torn.
you
Yeah,
go.
yeah. So,
Oh,
so
God, that's a good idea.
yeah. so, so you and I, we talk about the Oura Ring. We've talked about movement screening, movement assessment, all these things that allow us to be a little more proactive as clinicians.
Yeah.
In parallel, also allow me to be more proactive if I were
Yeah.
your patient. And
Yeah.
I think that people, when they do get hold of tech, when they do get hold of an Oura Ring, they do get all the data we can get from a screen, a force plate, some analysis of HRV. The one thing that I think you do very well, and I want you to speak to this, is I don't make the patient learn or speak like me. And I dispense with everything on the movement screen that you did well. And I use it as a filter to grab what's the painful pattern, what's the most dysfunctional pattern. My Oura Ring. Hey, everything looks good. O2 sat, temperature. Oh, sleep. That's the bad one. So I use these filters. And even though I ingest all the information, I definitely edit that down so most of my patients at any given time are only really aware that they're working on maybe one movement thing and one lifestyle thing.
100%.
And I find that when people listen to us or hear all the things we do, that's going to overwhelm my patient. Doesn't have to.
No.
If it stops with you and you withhold everything that's not PG-13, right? Because that's what we got to
Right.
do. They don't need all that.
Yeah. No.
And so
Yeah. Yeah.
yeah, and
Go
so
ahead.
I find that I do ask for accountability, but I don't ask for it in very often any more than two places. So start with that because
Yeah.
you're bringing us so many good uses of new tech and new innovation and the things that do probably make a cash-based practice as efficient and successful for the client. Because if you go somewhere for 4 months and pay your deductible, or you could have gone somewhere cash based for 3.5, 4 weeks with a little
Yeah.
bit of post monitoring, money's going to be the same. The outcomes, what the difference is. So
Yeah, exactly. Well, look, I always say you have to meet the patient where they're at. There are some people that love a lot of data and want more, and the majority don't. And so it is my job to try to figure out and decipher from their history, from their exam, what is going to be the biggest mover, right? What is going to impact their pain, their movement, their healing, their sleep, whatever it is, what's going to be the biggest mover? And then meet them where they're at. Like, okay, I think sleep is going to be the biggest driver. So let's just focus on sleep and then let's see what happens, right? So I think you're 100% correct. I think patients get overwhelmed with being given too many things to do, whether that they put it on themselves, or they're with a practitioner that's maybe giving them like lots of exercises, and you have to do this and you have to do that. That just their nervous systems are already overwhelmed. If a patient's coming in with pain, their nervous system's already off the chain. So my job is to do things that lessen that load. And sometimes that is just take things away, and then you see if you give them exercises and they come in and they're like, oh, I just didn't do them. Okay, well, why didn't you do them? I'm sure it's not just being lazy. It's usually because they're overwhelmed or they're not really sure how to do it. They don't know how to fit it in their day. So then you have to go, okay, well, what's reasonable? Is it 2 exercises? Let's figure it out. Is it when you brush your teeth? Is it first thing in the morning? Is it when you're dropping your kids off, and waiting for them, in the school line? How do we incorporate, this into your life where it doesn't become overwhelming? And if you're not doing that as a practitioner, then you just don't get the results because patients just can't buy into it. And usually it's just because they're overwhelmed with already their busy lives and other things that they're having to deal with.
All right, let's take a quick break here to tell you about Simeo. Simeo is our holistic wellness platform designed to give you the tools and resources to assess, manage, and improve your clients' and patients' overall health and wellness. Go to Simeo.com to sign up for a free trial today. That's SYMMIO.com.
We got 2 new courses I think you'll like. One's a deep dive on mobility and one's a deep dive on stability. We really unpack that and show you how simple single corrective exercises aren't nearly as good as a meal of mobility assembled in a flow, in a set of stations. Do the same thing for stability. It's sort of a new way of looking at things, but it's that same old functional approach, just with nice packages that actually give you huge dividends. I love that because if you can give them a feedback loop and they can check that periodically, and the 2 issues that I bring to movement is I show them how to check their painful pattern, but I also let them know that's not their dysfunctional pattern. So your forward bend could be what hurts you. Your single leg stance could be what's really bad. I don't want you to forward bend. I want to avoid that provocation, but I might have you work on your passive or active straight leg raise because you're on non-weight bearing, runs the same circuits, goes through the same motion, doesn't provoke pain that a weight bearing hip hinge would. So I ask you to check your pain every day, but I also inform you that your balance is what we're working on. But don't just tell me you're an 8 out of 10. Tell me you can check your forward bend if you want, do your little thing, because there's always a little dysfunction under the pain. But there's also dysfunction across from the painful pattern over there that's probably compounding this. Most of the time, they just walk out with 2 exercises, but they do realize one is checking my progress today, calibrating. The other is constructing maybe less of a reason to compensate. And we have that conversation, but I do try to keep those exercises limited because I remember the sheets that we used to hand out to people.
Oh my God, I know. They come in with stacks of them.
Yeah. I looked myself in the mirror one day. I wouldn't do that.
Exactly. But what's interesting? I don't know if you've noticed this, but I've noticed a shift when patients come in and they have had therapy before. And I say, hey, what exercises did your therapist give you? They said they didn't give me anything. They didn't give me anything in writing, which I find very interesting because it used to be that they got stacks and stacks of papers. And now they come in and they just say, well, I just did exercises there and they didn't give me anything to do at home. And I was like, really? Is that something that's changed? I don't know.
Well, I hate to say this, and like you, I've always been more influenced about I've always wanted to influence their behavior at home more than I want to influence their behavior in the clinic. Because I can get you lined up in here, but 2 sneezes from now or 1 box jump, you're going to lose it.
Yeah.
So I've always been trying to look for those opportunities and things they can do at home. But let's be honest, I can't bill you for exercises you do at home. I can bill you for exercises you do here. So let's make sure we get these done. And if I forget to tell you what to do at home, my note is written, my bill is made, right? It's not full circle, but unfortunately, that's the way the car wash runs some days, I guess.
Yeah, I know. It's been interesting. So
Give me, how long does it take you in the book to get to these 5 pillars that you're talking about? Didn't you say 5 pillars?
yeah, 5 pillars. So honestly, chapter 4, we start diving right in. So the first 3 chapters just gives more of an overview of, okay, what, how do you navigate this path? Why are we navigating this path? And what are some of the systems that we're going to use to help us do that? And then starting right into chapter 4, we start with nervous system regulation, because it's usually at the top, and of course sleep comes right after that. So yeah, so pretty quickly we get into the meat and potatoes of the pillars.
All right, I'm going to confront you right away. I consider you an expert manual therapist. All right, just because of where you've been and what you've done and what you got to do to close a case, you got to have the hands. You've got to have that 3D anatomy working for you. I honestly think the orthopedic and sports specialist of the day thinks, man, if I got dry needles and a laser and some good modalities and tape, that's all I need. And
Yeah.
I'm hearing you talk about nervous system regulation. And I
Yep.
know where you're going with this. I know where you're going because you can't force tissue to do what you want it to do. The neurological system has to agree with you. So,
100%.
my departure. I was classically trained orthopedic and sports, and all of a sudden, I start looking at these neurodevelopmental progressions and PNF saying, if I'm a strength coach, why aren't I using spiral and diagonal patterns? Why aren't I doing ground-based stuff? Well, 20 years later, the Turkish get-up becomes pretty popular. And I'm like, yeah, that's
Right?
right. And so, I've run into that same thing. Nervous system regulation to
Yep.
me was also, let's not put you in a squat rack when you can't even do a happy baby, right?
Oh yeah,
Because
100%.
you go sympathetic, you see a bad movement pattern, and then you try to verbally coach them out of dysfunction. They're already smoke checked. They're they're already at fear. They're already at fall prevention. So take me deeper into nervous system regulation. What are you doing?
So, with every new patient, we are doing a comprehensive heart rate variability scan. So, there's a lot of people that know about Whoop and Oura Rings, that looks at these different, metrics. So, we look at the heart rate variability, and it has a whole algorithm that will tell us how are they sleeping? What is their energy? How is this affecting how they're aging? How is their immune system? What's going on with their hormones? So we do that. And I will tell you, for any patient who scores below a 40, so the higher the heart rate variability, the better they are. The lower, there's a problem. So if somebody comes in and they're in a lot of pain, they're not moving well, and their heart rate variability is below 40, well, the first place I'm starting is the sympathetic nervous system and getting that regulated, because we know, and I really tried to do the research when I did this book to look at, okay, is what I'm seeing, is there research that supports it? And it does. Like, people that are in a high sympathetic load, it turns on the pain centers significantly. It is 126% that it activates those pain centers when you're in a high sympathetic load. So as a therapist, if I think I'm going to go do dry needling when somebody's nervous system is off the chain, or I'm going to push them with exercise, their body's just not going to respond. It's just going to shut down. So I have to look at, what can I do, whether it is certain manual techniques that actually create a rhythmical relaxation of the sympathetic nervous system, or use tools like Newbie, where we're resetting kind of and activating the vagus nerve, and, doing things that help to calm the nervous system down. Because once I can do that, then they're going to sleep better. Then they're going to start moving better. Because to try to get somebody to do movement or push them with exercise when they're in that high sympathetic load, I've just seen it doesn't work and they get frustrated.
So, first, we look at HRV on our wearables. You're talking about a device in your clinic. So even if they got a
Right.
wearable, obviously that's helpful, but you have a
Yes.
device because the one thing we always hear the skeptics say is, listen, unless you capture HRV first thing in the morning, you're really not going to get a stable signal. And that
Mhm.
goes all the way back to, I guess, my work in pro athletics using the Omega Wave a long, long time ago.
Oh, yeah, I remember that.
Yeah, what are you using now?
It's a system that was developed in England. It's through New PT Tech, which is a company that basically specializes in technologies for physical therapy practices. So, it's a software where you're basically kind of doing like an EKG. You're putting, electrodes on the wrists, and it is monitoring, the heart rate and the variability in between each beat for 5 minutes. And then there's a built-in algorithm that gives us all of this data. And as a matter of fact, we just beta tested. They're now doing kind of a sister unit that's going to be integrated, so you can actually test somebody in 30 to 90 seconds and know where they're at right now. And it will be integrated with AI, and AI is going to give feedback on, okay, like what's gonna get the person, feeling, better, get them out of that low heart rate variability. What can you do? What can they be doing at home that's going to improve that heart rate variability? Because we've seen when that heart rate variability is low, they're just the outcomes aren't as good.
When one of the things I've always tried to put alongside that is obviously I think anybody trying to distinguish herself in practice may need to start looking at this because we use the two words risk and readiness or readiness and risk. I just
Yep.
came from a tactical NSCA, state of readiness, state of risk, right?
Yep.
But when you start asking people, those two words come together in packages so much, they don't have the same definition.
Yeah.
Your state of readiness, listen, if
Yeah.
you're in pain, you don't have balance, or your HRV is crashed,
Yep.
there's very few things you're ready for. And the one thing I know you're not ready for is to be tested because your test scores, if somebody was taking an SAT or a
Yeah.
firearms qualification or a
Oh,
driving
yeah.
test and their HRV was crashed, they had
Yeah.
101 temperature, they were dehydrated and breathing shallow, this is
Forget
not
it.
them. This is
No.
a shallow version of them, and they're not going to perform well. And it made me wonder a few months back when we were talking to some of the people at the White House about the President's Council of Physical Fitness.
Mm.
You and I both have experience with youth athletes.
Mhm.
How many kids on the day we decide to do the President's Council of Physical Fitness test will have a state of readiness reflective of their effort is probably a good cross section of their physical ability. So
Yeah.
we've got a test set up where you only get rewarded if you pass. And there is no screening process to see if your state of readiness is here. Lee and I were
That's
blown
right.
away. The first time we did the movement screen, 20% of every athletic group for 5 years showing up for pre-participation physicals had pain on the movement screen with at least one pattern. So if you've got pain
Yep.
or an identifiable marker like HRV, let's agree that even though the protocol, the agenda, the treatment plan says it'd be great if we did this today, not to
Yeah.
you and not now. And
Nope.
most people don't know how to make that call. And I think you make that call effortlessly because it has such a big effect on your first treatment intervention. And so
Yeah.
there's manual things you can do, but you also said, what are you going to do for the vagus nerve if you think you can make that quick adjustment? How are you doing that? You mentioned Newbie or
Yeah, Newbie. So Newbie is a direct current technology that we use for multiple things. So we'll use it to get people out of pain. So with their nervous system is really, needs assistance, then we use what's called master reset. So we put electrodes along the neck and along the feet, and you turn up the stimulation where it's just kind of in the background. And, we'll pair that. We also use a technology called New Calm, which I've introduced you to. So we'll put the New Calm
And it works,
rescue
by
on.
the way.
I know, it's awesome, right? So we'll do master reset with a new calm. So we'll put, a mask on them and headphones, and we let them, I will usually do the rescue for 20, 30 minutes while they're on that. So that's activating the part of the brain that's getting them into that deep restorative relaxation so their body can start to heal. That paired with the newbie, that might be what I do on their first session, because, well, again, and then I'll give it to them. I'll say, okay, I want you to download the app and let's be using that at home. There's a sleep mode, there's the rescue mode. So these are things that they can start to do, so we can start to get their nervous system, better regulated. So those are some key things that we incorporate.
And obviously, in the podcast, we're going to put links to every product we mentioned, plus ways to get to you and get the book. So, but I love
Awesome.
that because, you know, I have changed my practice completely. I don't worry about the orthopedic stuff anymore. I'm not saying I'm great, but I got a good bag of tricks. So if it's a mobility or stability or joint, muscle, trigger point, inflammation, I'm good there. I'm worried
Yeah.
about who I'm doing it to at this point
Yeah,
and what state
absolutely.
they're in.
Well, because really, you can flare people up. So even the
I've
most
done it.
gentle, the most gentle, like muscle energy treatments, if somebody's nervous system is just off the chain and you go sticking needles in them, or you go do, manual work that their nervous system is, it's like, I talk to patients about a threat bucket, right? So you start adding these things, could be good for the nervous system, or not eating bad, not sleeping, or doing things that are positive like exercise. But when your bucket gets overfilled, then your brain goes time out, too many threats, and it outputs pain. So, adding something into the nervous system, even if it's manual therapy, in most cases it should help, but sometimes they may get really flared up because it was one more thing you added to their bucket.
And that used to be a hit or miss thing or clinical wisdom, right? You
Yeah.
took chances or you just see the stress on their face and you act accordingly. And
Yeah.
so, you ever heard the term, we got a crier in room 3? Because
Yeah.
you manipulate that neck and here comes a catharsis. A whole lot
Yeah.
of unknown tension just comes flowing out. And you're like, did I
Yeah.
hurt you? And it's like, no, I just got to cry. And I've been
Yeah.
there. I've seen it. It's uncomfortable, but now I know how to see it on people. But I never want to trust that clinical wisdom. I want to back it up with a number because it protects me from my own bullshit. And that's what I owe every patient. And so there's a lot of people out there that hear me talking about tech or new devices like, no, I'm good. I can read that. And I'm like, I want more than that, right? I don't want the pilot in the cockpit to say, yeah, I feel that thunderstorm is cool to fly through. I want them to know. So I feel I owe that responsibility. Quick PT geek question. What's the current form on the Newbie? DC, you said DC, AC?
It's a DC direct current. Starts at 500 frequency, and we can take it down to, I think, 5 hertz. So yeah, it's a range. So depending on what the way we use it to get people out of pain is very interesting. It's not like your traditional unit. You basically map out. So you take a sponge, and if it's an upper or lower quarter, you're going to map out, like, say, the whole upper quarter, the whole arm, and you're looking for what's called a hot spot. And that's a spot where the intensity goes up a lot. And so you find the first spot, then you connect it to a second spot. So you have 2 spots now. And then you have them exercise. You either do movements that might cause them pain, not right away. We kind of build into that. But if they can't move their neck by the end of the session, they can move their neck. They could start to fire, muscles, it'll help to inhibit muscles. So if, say, upper trap is really overstimulated, then it'll shut that down. So then they can now move more easily. So you'll do 10 minutes of exercise while you're turning the stimulation up. So you're nudging their nervous system enough where you start to change that signal that they're and that threat and that fear that they have of moving. All of a sudden it just totally changes, where people can't touch their toes, and you do a session and they're done, and then they can touch their toes because you've changed the nervous system.
And see, I'm so glad that you came to that, because I feel like we're empowered coming out of our education to really, really advocate and defend the tissue model. Tissue damage, tissue inflammation, tissue remodeling, healing, fascial planes. We're really good at getting swelling and pitting edema under control and getting circulation there. And almost every justification I've ever heard from massage and manual therapy, everybody's just, well, it increases circulation. Great. Now you've explained to me how you advance tissue healing. But when I go on stage and make somebody touch their toes, or you're able to unburden their neurological system in a single session, we didn't change tissue. We changed tone. And
yeah, we did. We changed the nervous system.
And I want to be able to argue both of those so well that I don't always have to default to heat and stim for circulation, right? And so what I find is so many people, their default argument is explaining to their patient that they're inflamed, okay? But they're not inflamed because of the way they move. What you and I are getting ready to unpack is we are in an inflammatory lifestyle. We've got blue light and broken sleep and shallow breathing and a lot of things. So the same foods that a lot of people could get away with, alcohol, sugar, high carb diet, and stuff like that, everything is good. That may not crash your system, but everything is crashed, and a high sugar diet and low sleep and dehydration, your inflammation goes through the roof. And so what I see is people doing a local anti-inflammatory treatment for a global inflammation problem, but where they seem not to be able to talk intelligently with their patients is when they do, in a single session, change muscle tone, unburden the system, and all of a sudden there is this release of tension, or the person feels better. Well, you can't explain that with circulation anymore. You can't explain that with tissue healing, but you can explain that with this neurological system. And basically, I just tell people, I'm like, your body holds a lot of stress that your mind asks it to. And if we could ask it to release that stress, you should feel it pretty quick. Now, I've never seen a fully toned patient, and I've never seen a fully tissue patient, right? There's always a little bit of tissue stuff going on. There's always a little tone stuff going on. But you can usually identify when this is a tone-driven person and when this is a tissue damage person. So let's be honest, absolutely. 2/3 of our people, if we could manage the tone, the tissue is the easy part. But I find that so many people lack the ability to discuss numerically with devices, techniques, and applications how you cool them off, not just how you deflame them.
You've got to do that. You've got, I just find that, we're so much more successful, picking the right intervention, with what we're going to do with patients. That's, there's the game changer. It's just like, you just got to pick the right, the right thing at the right time. And, a lot of really cool things happen when you do that.
No, I love that. Okay. Patient comes in, HRV, the first thing you're doing, are you doing that after the history, before the history?
So I do the history, because I always say, first of all, I feel like patients want to tell their story, right? And how often do they get to spend enough time with a clinician that they just want to unburden? They just want somebody to listen to what's going on, because nobody's really sat and listened to them. They've shuffled them here, there, and everywhere. I got 5 minutes and then they're out the door. So, I like to let patients really, tell their story. From by the end of that history, I usually kind of know what's going on, and I'm just going to confirm it with my exam. So then I go into my exam, I kind of get a feel of, okay, what's the lay of the land? And then I do my heart rate variability. Then we also do an in-body scan, because particularly for lower extremity injuries, I want to get an idea of our, and especially with all the new weight loss drugs and, the different things that are going on, are they inefficient or insufficient with their muscle? What's happening? They have a lot of visceral fat? So I like to get, the lay of the land there. And from there, I then pull everything together, because now I'm like, okay, now I have all the pieces. And then from there, depending on what I felt was predominant, I might do a little manual, or I might go right into kind of nervous system regulation and start talking about sleep, because, that becomes, the number one thing that they need to do that's going to really flip that switch. And then they will get a 15-minute nutrition consult, usually within a week of their evaluation, and we pick something from their eval. It could be that we identified inflammation. They might have gut issues. It could be sleep. It might be hormones. So depending on what it is, then we'll kind of target that for them to review that with our, integrative health specialist, and see, sometimes those are bigger players than anything. And I gotta get their gut in check, and I gotta get their inflammation under control. Especially those patients that come in and have multiple pain complaints, right? It's systemic. It's not just, oh, my shoulder and my knee hurts. It's my hands hurt and my legs hurt, and all, and it just doesn't all add up to, this is not musculoskeletal. This is systemic. And you realize, well, they're burdening their body with sugar. And you take that sugar away, and guess what? Oh my God, I feel a lot better, and my muscles aren't as tight, because you've changed the biology, and you've, again, like you said, you've unburdened the system.
No, do you outsource nutritional counseling, or do you have somebody local that does that for you, or somebody on staff that does that for you?
We have somebody that's on staff, and she takes care of that. So, she does all of those consults. And then, if we feel that this is a bigger issue, and the patient's on board with it, then they'll go into doing some work, with that person, because sometimes, like I said, that's the key button that we need to, really, improve, how this body's going to heal and function.
No, and I think that's important, because even though I've had everything from relationships with precision nutrition where I could outsource it, and there's so many ways to get blood work done right now, but for those clinicians that are listening to us and may not have those resources, I literally think that if you look at gluten, dairy, sugar, and alcohol, and really
Yeah.
try to, especially if one of those is predominant, a daily,
Yeah.
if you can
Yeah.
pull that back, I don't even need any blood work. I'm just saying, hey, I'm not telling you how to live. I'm telling you how to rehab. And if you want this rehabilitation process to go as smoothly as possible, don't do anything else to upset the apple cart. And alcohol, sugar, dairy, and gluten, not because they're bad things. We've been doing bad things with wheat and dairy for a
Right.
long time.
Right.
Alcohol and sugar weren't nearly as available. They were hard to come by at one time
Yeah.
on earth. So you
Yeah.
enjoyed them when you could, but not every day. And so I
Yeah.
find that a lot of people just don't get how much of a driver that is. But I've literally seen people eat like they're supposed to during rehab, and without a lot of MSK changes at all. A lot
Mhm.
of great changes in mobility and motor control. Their pain scale goes down 3 points,
Yeah.
and their
Oh,
knee
yeah.
still needs a lot of work. But that
Yeah.
was gas on
Yeah.
fire that didn't need to be there. Yeah. So,
Exactly. 100%.
um, back to the 5 pillars, because we
Yeah.
did part of that. Give me those 5 pillars and then tell me how you're looking at that again, because neuro came up. But
So nervous system regulation. So how we're looking at that is doing our comprehensive heart rate variability. And then I also, it's not so much nervous system, but again, the in-body body comp. Then sleep. So our heart rate variability scan will at least highlight for us if sleep is an issue. And if it is, then you start to ask more questions and you can dive into that. Then it's biology, right? It's inflammation, hormone testing. I'm getting an idea if somebody's coming in with ulcerative colitis and, they have diabetes or, heart disease or whatever it is. I'm going to pick up those things if I start to see, especially if I'm suspecting systemic issues, then I know biology I've got to address. Then of course movement, because movement is the baseline of what we do. And then environment. I mean, believe it or not, Gray, I mean, I'm sure you see this, but people's environment, whether it's they're sitting at a computer all day, how they're sleeping, what they're wearing, what they're breathing in, all these things impact. I can't tell you how many patients I've caught mold, issues at their house because, they just weren't responding and the way that their symptoms were presenting. I said, something's not right here. And so environment is another piece that, again, how do I offload the burden? And if you've got a lot of burden with all these pieces, and you got to figure which is the biggest lever, right? I just need to know what's the biggest lever. If I pull this lever, everything's going to start changing. And so my job, I feel like, it's to find the biggest lever and to help them incorporate strategies and give them the resources to start to address that one pillar. And that's what we try to do in the book. I try, we give a lot of resources outside of the book that they can tap into where they can do a quiz and they can just figure out, well, where am I? What is my biggest pillar? And where do I even start? So they don't get overwhelmed. It's like, okay, and if you don't know where to start, then we're going to start with sleep and, and your nervous system health. So
And I like the fact that you've put a lot of your simple explanations and tricks, if you will, in the book, because I think a lot of clinicians that are listening to us say, I wish I could do more of this, but until we role play, and I've done this in clinical in-service and stuff like that, I literally role play how to take a history because we do have these patients that have had bad experiences. And I'm like, I can't make the bad therapy of your past go away. But I can help you. So if you want to tell me everything the other therapist did or didn't do for you, that's fine. But this is you, this is me, this is us. I'm in the same profession as them, but I'm not them. So if you want to get that off your chest, that's fine. But the history's about you, not about everything that didn't work. But you're welcome to tell me that, but let's get on through that. But there are things that I think that you're going to do in this book that are going to teach us how to approach those topics better. And the one topic that I used to shy away from was when I'm examining somebody who's obviously obese.
Mm-hmm.
And unlike sleep and HRV, I can't change that in a single session. But I know that obesity is a risk factor.
Big time.
For metabolic and musculoskeletal issues.
Yep.
And then we start seeing how many other things go hand in hand with the obesity. And when we start looking at COVID deaths and slow walkers and obesity and all these movement and morphological signs that we're forecasting right away, if you can recognize somebody's significantly overweight from across the parking lot, there's a 98 to 99% chance they have at least 2 metabolic issues. That's a better predictability than most radiologists have with a fracture.
Yep, absolutely.
So we got to approach it. We got to bring it up. We're not fat shaming people, but a type 2 diabetic is going to take longer to get through a frozen shoulder. And an obese low back pain person, statistically speaking, is going to take longer to get through this rehabilitation process. But it doesn't mean they got to lose weight during rehab. It means they got to get a handle on some of those things that are creating that toxic environment, because I do think that at the headwaters of metabolic syndrome is poorly controlled insulin. So we're right back to sugar and inflammation. And one of the reasons that we do see people put on weight, the healthiest way to handle inappropriate blood sugar is to get fat, because you disperse that load of sugar across more tissues and it doesn't hurt. The most dangerous diabetic you can be is a thin diabetic, because for some reason the body already knows, if we're going to be stuck in this horrible nutritional toxic life, this adipose buffer that we carry on our body, believe it or not, buffers everything. It also inhibits healing, right? But it's literally a response, not of somebody who's being lazy. The system doesn't like what you're putting in and doesn't like what you're putting out. And so it just buffers the load by creating insulation. And so, but it's got to come up. How do you approach that? How do you, I mean, everybody people know they're overweight. They just don't think it has anything to do with their knee, because when you say, well, I think your arthritis, a little bit of weight, and they're like, well, my other knee's fine and it's carrying the same weight, which is logically speaking. But when you are having inflammation or tone issues, the fact that you're overweight tells me something about your history, that this has been going on for a while and that you're not going to recover as quick, because there's probably some lifestyle issues that are unknown yet, because not everybody's heavy for the same reason. So.
Yeah. Well, and that's why it's so great to pair the heart rate variability testing with the in-body. So with the in-body, if I'm seeing low muscle, and they're under, let's just say, where they should be, and their visceral fat is over where it should be, and then I go to heart rate variability and I see they're poor sleeping, their immune system's in the tank, their hormones are, all these things. And I start to ask questions. And then it's like all of a sudden the light bulb goes, so it's almost like you don't have to be like, hey, but I use visceral fat to be like, okay, look, when we get more, weight around our belly, that is going to put us at increased risk for heart disease, diabetes, cancer. That paired with you're not sleeping well, and if you look, oh, your chronological age is this, but you're aging faster. So all these things, these can be controlled through a lot of lifestyle changes, and it's going to impact your healing and your recovery. So that's usually how I approach it.
No, and I like the fact that we've used in-body too, and even though it's just a bioelectric impedance and mostly used for body comp, I love the strategy you're bringing to it, because you're right. On an ACL patient, I can see the atrophy in the quad and hamstring on that in-body because there's just less muscle tissue, which means there's less water on that side, which conducts electricity poor. So I honestly think that's very elegant, is looking at body composition, not at obesity, but relating that back to the fact that, you come from the athletic world. In many cases, you're putting out a fire that is due to competitive stress or training stress. It's pretty easy to put athletes in an overstressed category. And even though most of our clients in general practice would say, maybe I'm overstressed, right? They're literally under recovered. And to me, those are two different things, because the minute you pull that marathoner off of their training schedule, they recalibrate pretty quick. So you can say, you were overstressed. We've got to get back up to that load. But believe it or not, interval training is going to treat your metabolic system better than distance training right now. You just can't handle that load. So all we got to do for athletes sometimes is mitigate that stress. Let's be honest, many of our patients aren't hitting 7,000 steps a day when we first get them. So you can't add stress to somebody who's already under recovered. And all I'm trying to do is put a cherry on top of everything you've been saying, because you've given us metrics for proving to somebody they're under recovered and also proving to them how quickly we can get that recovery on an upward trajectory. So I love putting myself in a binary bind. Are they overstressed or under recovered? And when in doubt, assume under recovered. If you know exactly where the stress came from and you are their PT on the tour, then you had somebody who was great right up until the tournament. They're overstressed.
Yeah, exactly.
No,
Yeah.
I like that.
That's a big one.
So as a clinician, I think I can not only put myself in the patient's place, because I've told a lot of clinicians that about our little Simio app. Do your own wellness survey. How would you talk to you about this? Because or how would you talk to the other clinical colleagues about this? Because that's literally the starting point. And a lot of therapists just don't feel they had the training in school to talk outside the musculoskeletal system.
No,
but
they don't.
Well, if it's a risk factor that affects the outcome, we got to talk about it. And that's where when Kyle Kiesel did his white paper in International Journal of Sports Physical Therapy, identified, I think, 14 or 15 risk factors, right? Balance, movement, pain with movement, confidence and recovery. Obesity's right there. It's right there as a risk factor. Low grip strength, low cardiovascular fitness, all these things. But I think if you can check 5 out of 15 of those, it's like metabolic syndrome. You're in musculoskeletal syndrome, and a syndrome, classically speaking, from the Greek or Latin, mean things that run together. You don't have to treat them equally. Just like you said, the headwaters of many of these things is just sleep and HRV. And so if we can't get that under control, you're going to lose the case. So
no, I mean, it's so true. And I my hope is that the book not only helps clients, right, navigate, the system, better treatment, take, responsibility for themselves, but like you said, for clinicians, because there's not a lot of guidance, there's not a lot of training, for clinicians to figure out, well, how do I start to even look at some of these things and, talk to my patients, and what kind of, resources are out there to assist with that. So I'm hoping that they'll find it also helpful, just to start to kind of tap into and, kind of see why might not my patients be getting better because of some of these factors.
Well, the other thing is you've had to treat yourself. I've had to treat myself. I know the value of sauna. And I know that if I had some longstanding problems, great investment. If I had to pick between hyperbaric oxygen chamber and sauna, believe it or not, the sauna is going to be more economical and it can be more part of your lifestyle. When you're in a very toxic situation, you can't beat hyperbaric oxygen, but it's barely an argument, because when we look at every culture that successfully had dry heat sweats across time, we got a 5,000-year history of people aging gracefully using sauna, where you might not be able to get all the steps in every day, but believe it or not, there's a cardiovascular load and a detoxification load in that sauna. So I always try stuff on me first. I'm sort of a Tim Ferriss. Yeah. So Oura Ring, sauna, hyperbaric oxygen chamber.
100%.
I dry needled myself everywhere I could real hard before I did anybody else. I sort of stayed away from my face and spine, but I'm like, probing on myself. But literally, most clinicians that come to my workshops, they're just as jacked up as their patients are. And Lee and I,
if not more.
So my advice to clinic leadership and clinicians across the board is physician, heal thyself. I mean, literally, if you're ready to look in the mirror and talk intelligently to yourself, you don't have to read my script or Lisa's script to do this. You got to confront your own stuff first. And it's right there under the surface. I've done SFMAs on PTs for 20 years. They're just as Lee and I did Simio on 3 different groups at Perform Better. And our audience is full of PTs, chiros, ATCs, personal trainers, and strength coaches. They scored the same, if not a little worse, than the general public first responders.
Shocker.
But yeah,
It's true, but yeah, I mean, it's, I mean, look, that happened to me when I was on the tour. I talk about that in the book. I was working 10, 15-hour days, traveling international, not sleeping well, eating like garbage, no time to exercise. And, I was gone for 8 weeks. I came home. I didn't do anything other than brush my teeth and lean over to wipe the mirror. And I thought somebody stuck a knife in my back.
yeah.
And it was literally in that moment, I was like, okay, I need to change what I'm doing because I had been doing that for years. And so as therapists, we're all about helping our family, helping our clients. We want everybody to be well, but you know what, if the plane's going down, I better put my oxygen mask on first before I help everybody else. So what I say to clinicians is make sure you're putting your oxygen mask on, and you gotta listen to your own body, and you gotta take care of that first, because if you don't, you're not gonna last too long.
Well, and it's funny because almost every time on a clinician, when we're movement screening or movement assessment, you find a bad movement pattern or something like that. They've always got an excuse and a story.
Yeah.
So as long as we can make it about one thing, we don't have to look in those other places. And I ran out
Yeah.
of excuses. I
Yeah.
I literally ran
Yeah.
out of excuses.
Yeah.
So I literally had to. You feel that putting the oxygen mask on yourself first, especially if you're a clinician and if you feel like you were called to this profession for more than just
Yep.
economic security. If you
Yep.
truly want to embrace the path of a healer, then you end up being a shaman for somebody, right? Even the chief
Yeah.
needs a shaman. And so,
Yeah.
at some point, you've got to really look at yourself and say, it's not selfish to put the oxygen mask on you, because if you know that if they're in sympathetic drive right now, they're going to
Yeah.
be a poor historian, their pain's going to be amplified, and they're not going to process or be as logical as they would be if they were in rest digest mode right now. Well, what if you're the clinician and you're sympathetic? You're going to make poor
Exactly.
decisions.
So how do you show up? How do you show up? I mean, if you're all, jacked up, then
Oh,
yeah,
yeah,
you
6
can't.
cups of coffee. That's how I showed up. I can get through this crap. I'm tougher than you.
It's true. Many are doing that.
No, and it at my age now, I do wind up talking to a lot of clinicians that are on the other side of 40. And part of me is just saying, I can't teach you much more about taking care of somebody orthopedically, but learning to
Yeah.
take care of yourself will open up a
Yeah.
whole new domain of your practice. And
Yeah.
you can have as much or as little tech as possible, but if you're going to talk homeostasis system wide, and you don't bring numbers to the game, and you don't bring a little bit of tech objectivity to it, you're going to be wrong a lot. And
Yeah.
so I I do value this tech, and I do value filtering this tech for what it is. What else am I going to find in the book as I get through it?
So once we go through all the pillars, so I feel like once you address the major pillars and we get people out of pain and we're regulating their nervous system, well, then we look at, okay, well, what about sport, exercise, athletics? So there's a whole chapter in there on endurance athletes. So all my experience in working with athletes, overhead and rotational athletes. So the differences between these athletes, and obviously there's a lot of similarities with, training and recovery, and so all the tools and resources that get unpacked are in those chapters. And then we do one that's on the senior athlete. So, and kind of going through some basic metrics, like you mentioned, like grip strength, VO2 max, like what are the longevity predictors, and what can you start to look at, now really you can do it if you're younger, and then you can do it as you're aging. But what are some of those longevity predictors, and then some strategies of, okay, well, now what do I do? And some different technologies like BFR that, I mean, I had the story that I talk about in that chapter is of a woman who was, like 86 years old, who came to me, who could barely, walk to her mailbox. And we started using BFR training on her. She was a physician, very well educated, had done high intensity training all her life, was very fit, and all of a sudden now she can't walk. Well, we empowered her with getting her own bands, and I literally just saw her. It's been a couple years, and we did a telehealth because she wanted like an update on her exercise program, and she's still using the bands, and she's empowered, and she feels better. And now she's not having to load her joints as much. She's not having to lift so heavy. But again, she can biohack, using some of these technologies. And she travels all over the world, and she can walk 20,000 steps, and she's doing great. So
talk me
so
through
yeah,
blood
so
flow restriction for a minute, because I value your opinion on this. I remember when the first time I was exposed to it, I thought it was being used a little bit inappropriately because it was being used more as a performance enhancement thing,
mm,
not so much
mm.
a rehab tool. Talk me through how you think blood flow restriction is actually working and what sets us up for that to be a good reset.
So, the thing that I love, and I started using it myself because I have very bad arthritis in my hands. And so for me to lift heavy is very challenging. So I was introduced to it. I always heard about blood flow restriction, and, many of the blood flow restriction probably that we're used to, you're hearing about, are need to be run by a professional, right? It's got to be very specific on blood flow. But there are now, products that you can teach a client, and you can teach them how to use it. So I love to use it because it's going to boost my growth hormone. It's going to increase my nitric oxide. So it's going to help with my tendon health, it's going to help with my pain. And so many of the patients that we're rehabbing, they can't lift heavy, and patients don't want to exercise that long. So I only have to exercise for 20 minutes, and I use my blood flow restriction. So it's going to help me as I'm rehabbing. I've rehabbed, patients that have had like total hips, and we start using it pretty quickly. And so it speeds their recovery. It gets them there faster. And then they go home, and they can be using it themselves. So I do that 3 days a week, for 20, 30 minutes. I've got my workout routine done with my blood flow restriction, and I'm good to go.
I love it.
Also great for weight loss, bone health. So there's lots of things that, I'll tell patients, like when you're talking about weight loss, I'm like, hey, let's put the blood flow restriction. Let's just go walk for 20 minutes. Like, just doing that is going to start to help them, or get in the pool if you can't walk, and use your blood flow restriction. So it's like, how do I kind of supercharge but not overload and overburden their system?
Where are your blood flow restriction points, or do you have go-to points?
So, yep. So they're going to be above the bicep and kind of like just below the groin.
Okay. Do you know, or do you feel there's any mechanical effect other than blood flow restriction going on with the tourniquet type pressure?
I mean, it's, my understanding from the training that I did with this particular company was that it's not really creating a tourniquet. It's really more slowing the venous return. So, I mean, look, I'm sure maybe something mechanical, but I'd have to think about like what mechanically, obviously you're slowing, the return.
So aren't you also increasing CO2?
Yes, that's
And
true. Yep.
retaining your CO2 is
Yep.
awesome for pain control. But a lot
It
of the
is.
areas I've seen where the blood flow restriction pressure is being applied are also areas at the base of the deltoid above the bicep where multiple fascial planes come together. And as those areas get squeezed, they also get lubricated as a rebound, meaning if you compress and release, you get a rebound. And so I think there's obviously, I think one of the biggest things is that CO2 controlling that and getting that oxygen O2 balance back where it's supposed to be. Yeah. But I also think mechanically speaking, there's probably some fascial compression release that's creating a little bit more, synergy with when you create tension in one fascial line, you don't get this unnecessary pulling everywhere else. So,
I think that's definitely multifactorial. I mean, I've felt it in my own body, how I feel after, during. So it's a great tool.
No, I love that. Well, what I love about what you just did for me and our audience is you gave meat to the word wellness, because I still feel it's such a fluffy, ambiguous word. And yet, if your state of health tells me if you're ready or not, your state of risk tells me if you're looking at a life of wellness in the future. Wellness and fitness are both predictions. Whereas your state of health and your current level of performance, those are measurable right now, right? Yeah. I can see how far you can hit a golf ball, and I know what your vital signs are. So those are non-negotiable. Right. But everything we say under the umbrella of wellness and fitness is a projection. Are you going to be well and stable in the future?
Yep.
And are you fit for your environment? These are predictions. They can't be proved. We either got to see, are you healthy tomorrow, and can you hit a golf ball tomorrow? And so I think that we have to really get our prognosis heads on, because diagnosis doesn't equal prognosis. Diagnosis plus risk factors equals prognosis.
Yeah,
and so your current problem and your current state of wellness put together in an equation tell me where this is going to be. And I had to tell myself that, because I was always doing that math in my head. This is going to take a little bit longer. Well, why do you think it's going to take a little bit longer? Because of these 4 things. Well, let's talk about these 4 things, just like we talk about range of motion and strength, and get them back where they need to be then. So,
exactly.
What's the name of the book? You got to tell them.
I thought you'd never ask. It's called Be Responsible Because the System Isn't.
Gotcha. And I think one of the statements you make is, let's not put any more faith in healthcare than we need to, because it's a business. Just like entertainment, just like serving food, they're going to make a profit first. And
that's right.
Right. And so right now,
be informed.
Yes.
I want to empower people that find the right practitioner, right? Who's going to collaborate with you, versus you go to that, clinician who just might be like, hey, it's my way or the highway. And they're not going to, have a partnership or collaborate with other providers. I mean, I have a whole network of people that if I can't provide the patient with what they need, then I want to find somebody who does. And I want to be able to text them, call them, have a conversation. And so, you don't have to settle. You can find, there are clinicians out there. It's harder to find. You might have to pay cash, but, there are options out there, so hopefully it gives people, it empowers them, it gives them some knowledge and knowing, what questions to ask, and what, resources might be out there that they can at least inquire about, even to their, to their clinician.
No, I just love strategies that aim more at proactivity than reactivity, and that's what you're giving the client, so they can understand when they've got a forward-thinking clinician as opposed to a reactive clinician. I've been both, and I've also probably shirked my responsibility in the lifestyle or wellness part and just tried to be the joint jockey or the muscle guy.
Sure.
And
Didn't we all?
yeah. And so, I want those listening, take it from two people that are geeks about pretty much everything in this domain. And we're still making sure that we're treating a person with a knee, not a knee attached to a person.
Yeah.
That's sort of, that's what I get out of so many of our revelations, looking back at 30 years of practice at every possible level. And believe it or not, my biggest success in pro athletics was I was looking at wellness. And I wasn't talking about it because, let's be honest, they're flying me across the country to look at a knee that 5 people who are just as good with knees looked at.
Yep.
The last thing I'm going to look at is the freaking knee, because I think it's been weighed and measured, right? And I may have a different technique or a different style, but I'm going to look at the hip, I'm going to look at the ankle, I'm going to compare it to the knee on the other side. I'm going to do some, that's the difference. I was looking outside
You're looking
of
at the whole thing.
Yeah. So you look outside of impairment and you start looking at function. Well, what do you do when you look outside of function? You get right back to lifestyle, wellness, and behaviors. So,
yeah, exactly.
No, that's awesome. Where can people get the book?
Well, my hope is that it's going to be published on Amazon in January.
Okay.
So it's coming. It's coming in January, and so we'll obviously have it on our website, which we can give you the link to, and then and then they'll be able to find it on Amazon.
Now, does every patient coming to your clinic get like a free copy or something like that, or a?
No, I don't know about a free copy, but we do always give a gift, to our patients. So perhaps for a period of time they might be getting an autographed copy from me. So yeah.
No, I think that's good, and I also think that one of the things that they're going to be going through the process. You're going to be doing a lot of this for them and having a lot of those conversations. But I honestly think that if you were to ever develop the series of cliff notes that goes alongside of it, I could see clinics handing these out, helping their patients make the most out of this time. Because let's be honest, if you want your rehab to go smoothly and quickly, you got to do more than just your exercises. That it starts with, let's make sure they're doing something outside of the clinic, but it doesn't all just have to be sets and reps. And that's what I love about this. So.
Yeah, well, you and I have talked about that. So that's going to be phase 2. Phase 1 is to get it out to the patients, and phase 2 will be to get it to the clinicians. So, so that'll hopefully be the trajectory of the book. Well,
I hope the clinicians listening to this will support you and also aim it at them before they aim it at somebody else, because you come to clinic a different way. And I honestly think once you get 30 years behind you, you're either looking at burnout or light the flame again. And I like lighting the flame again,
Me too. Me too. I love it. Well, I appreciate you having me on the podcast and all of our banter and, conversations that we've had, over the past year. It's just been great. And, you've brought so much, I think, to our profession. And, I love collaborating on these things with you.
No, I appreciate the opportunity. I'm glad that you got a chance to look at Simeo and see what we were trying to do, because we're headed in the same direction, and we're doing that. But no, I am just unbelievily flattered that you would come on here, you would share this with us, and I'm really impressed when you can geek out with me on all the new stuff, just like we did on the old stuff. So this is one of my favorite geeks, guys. I could geek out with her on this clinical workout, manual therapy stuff for days. So
awesome.
No, it's awesome. Good. You are an artist, but you didn't leave the science behind. Thank you.
Awesome. Well, thank you. Appreciate it.
All right.
All right. Till next time, geek.
Yes, sir. Geek.
If you want to learn more about today's podcast or dive deeper into functional movement systems information, check out some of the resources and offers we're providing in the description. That will do it for this episode of the Movement Podcast.
Thanks for listening, and if you liked what you heard, please take a minute and subscribe and review.
If you want to learn more about our system and take the next step in your own movement journey,
visit us at movementpod.com.
Until next time, be sure to first move well,
then move often.